Hello everybody, my name is Mohamed Sadiq and today we'll be discussing the QRS interval. We had learned how to interpret rate, rhythm, axis on an ECG. We looked at the P wave and the PR interval, and now we're going to look at the QRS interval in detail. The QRS interval is generated by depolarization of the ventricles. Depolarization proceeds from the AV node through the His-Purkinje system, including the left bundle and the right bundle branches, and all the way to the myocytes in the ventricles. Following that, the ventricles contract. It's important to note that unlike the atria, where the right atrium depolarizes before the left atrium, both ventricles will depolarize simultaneously and contract simultaneously under normal circumstances. When we look at the QRS interval, we see multiple deflection. The Q wave refers to the first negative deflection below the baseline. The R wave refers to the first positive deflection above the baseline. The S wave refers to the negative deflection after the R wave. If there's another R wave following the S wave, it is called an R prime. This is an example of a normal ECG. And here you see that in leads V1 and V2, there's a small R wave and a large S wave and no Q waves. But when you look at V5 and V6, there's a small Q wave in lead V6, followed by a large R wave, and a small S wave is seen in V5. So why does the QRS complex look different in every lead? Well, it's because of the vector of depolarization. And depending on how the vector of depolarization proceeds, each lead will give a different vector and be positive or negative depending how depolarization moves through the heart. So here we look at the precordial leads. We've reviewed how these leads are placed in a previous talk. It is important to note that the reference electrode for the precordial leads is Wilson's central terminal, which is composed of the average of the electrodes placed on the limbs. Because V1 is on the right side of the heart, any depolarization proceeding left to right will be positive in V1. Conversely, right to left will be negative in V1. Because V6 is on the left side of the heart, any depolarization proceeding right to left will be positive in V6, and left to right will be negative in V6. And of course, V2 to V5 will be a smooth transition between V1 and V6. So looking at the wave of depolarization, following conduction of depolarization signal from the AV node and down to the His-Purkinje system, the interventricular septum will depolarize first by receiving Purkinje fibers from the left bundle. And because it receives Purkinje fibers from the left bundle, the septum will depolarize from left to right. This creates a positive deflection, a small R wave in lead V1, and a negative deflection, a small Q wave in lead V6. Following that, because the left ventricle comprises most of the myocardium, in other words, it's thicker than the right ventricle, the major vector of depolarization will be determined by the left ventricle. And the overall vector of depolarization will be going from right to left, which is going to be negative in lead V1, giving a deep S wave, and positive in lead V6, giving a large R wave. Lastly, the base of the ventricles will now depolarize. This signal will be mostly seen in the lateral leads, closer to the base, and will be a negative deflection in lead V6. And that's what comprises the QRS complex, where you have a small R and a deep S in lead V1, a small Q, a large R, and a small S in lead V6. And the transition between V1 to V6, you will see that the R wave gets bigger and the S wave gets smaller. Now, for the QRS to be narrow, depolarization must proceed through the His-Purkinje system. If it's proceeding through muscle cells, it will be a slower process, and the QRS complex will widen. But when it proceeds through the His-Purkinje system and both ventricles depolarize simultaneously, you will get a narrow QRS because the speed of depolarization of the ventricles will be very fast. And the duration of a normal QRS is less than 0.1 milliseconds, which is less than 2.5 small squares. And here, if we zoom to leads V1 and V6, we'll see that the QRS duration is less than 2.5 small squares, so this is a normal QRS width. But what's going to cause the QRS to widen? Well, we said that for the QRS to be narrow, depolarization must proceed from the AV node through the His-Purkinje system and depolarize both ventricles at the same time. Anything that interferes with that will cause the QRS to be wide. Some of these examples include bundle branch block. When there is a bundle branch block, either left bundle or right bundle branch block, one side of the heart will depolarize quickly through the His-Purkinje system, but the other side of the heart will depolarize slowly as the signals travel through myocytes, which have slower conduction properties, and thus the QRS is going to widen. This is an example of a left bundle branch block. We will talk about bundle branch blocks in more detail in a subsequent lecture. Ventricular rhythms or arrhythmias originating from the ventricle will have a wide QRS because they're not following the His-Purkinje system, and rather depolarization proceeding myocyte to myocyte, which will be slower and will widen the QRS. This is an example of ventricular tachycardia, which is a rhythm originating from the ventricles. You may also have single beats from the ventricles, and these are called premature ventricular contractions. They are also wide, again, because they are coming from the ventricles and not following the His-Purkinje system. And here's an example of premature ventricular depolarizations or contractions that are coming in early, hence they're called premature, and generate a wide QRS. In patients with pacemakers, when you pace the ventricle directly, you generate a wide QRS because you're not going through the His-Purkinje system again. In these cases, it's easy to diagnose why the QRS is wide because you see pacemaker spikes on the ECG machine telling you that there's a pacing signal leading to depolarization of the ventricles. Pre-excitation, which is the presence of an accessory pathway that inserts from the atrium to the ventricle outside the AV node, can also lead to a wide QRS. Here, the accessory pathway leads to earlier excitation of the ventricles because it doesn't have the same decremental properties of the AV node. This will lead to the QRS starting relatively early, and because depolarization from the accessory pathway is proceeding through muscle, not the His-Purkinje system, it will lead to a slow and wider QRS onset. Here we see a short PR interval because of the pre-excitation and what we call a delta wave, which is slurring of the initial part of the QRS caused by the accessory pathway. We will talk about the accessory pathways in more detail in a different lecture. Metabolic abnormalities that cause cells to conduct slower, including medications such as antiarrhythmics or hyperkalemia, can also cause the QRS to become wide. And finally, artifact on an ECG can give the impression of a wide QRS and can sometimes be misdiagnosed as ventricular tachycardia. This is an example of an artifact on an ECG. This can happen for whatever reason, including poor contact of the electrodes, motion of the patient, seizure activity, muscle fasciculations, etc. And for whatever reason, you get artifacts that look like a wide complex rhythm. But if you look closely and you trace the QRS's back, you'll see that the true QRS is buried within the artifact. It takes a lot of practice to recognize artifacts from a true arrhythmia. So in summary, the QRS complex is generated by depolarization of the ventricles. The usual depolarization of the ventricles occurs through the His-Purkinje system, and both ventricles depolarize simultaneously, generating a narrow QRS less than 2.5 small squares. Thank you very much. I hope you enjoyed the lecture. Please subscribe to keep an eye out for future lectures. Thank you.